Okay, so we're going to talk about thyroid tonight. Probably the first 18 slides, you're going to figure out what most medical people know. So when I went through and did my internship at North Kansas State Hospital, basically they said, if your TSH is off, give them medication, go on your way. There's a lot more to it. So I'll kind of give you more of the oversight of how endocrinologists look at it. So when we look at thyroid conditions, there's really two things you're talking about. You're talking about low thyroid and high thyroid. So low thyroid is called hypothyroid, and the symptoms are pretty extensive. So if you go through this list and look at yourself, you will pretty much pick out several things you have there. Everybody has something. It doesn't mean you have thyroid problems. You could have other things. But usually you're tired, you're gaining weight, your metabolism's slowing down. That's the main hypothyroid issues. Hyperthyroid is just the opposite. We see a lot more hypo than we see hyper. Hyper is diagnosed a lot quicker by medical doctors because you get sick rather fast. You tend to lose weight, can't put weight on. You tend to have diarrhea. You tend to be anxious. You tend to be excited. You're not sleeping. And so these people get sick much faster and pretty quickly get diagnosed. So there are around 20 million, and I should have highlighted this, diagnosed thyroid patients in the U.S. It's probably the number is 3 to 4 times that are not diagnosed. I was just working up a case just a minute ago that has every sign of thyroid problem, but no one doctor actually did all the testing. One doctor did one test, one doctor did one test, one doctor did one test, and so they missed it because they didn't look at the total picture. So there's a lot that way. If you're female, you're 5 to 8 more times likely to be diagnosed. Men do not get tested for thyroid issues. It's just a rare thing. And so when you start testing them, the number goes up pretty fast. The medical world is really quick to give a guy testosterone. And so they say, oh, your testosterone is low. Well, why is your testosterone low? Well, it just is. It's because they have a thyroid problem. So it's missed a lot of times. So what is the thyroid? When we say thyroid, when we refer to it as the thyroid, we're usually talking about the gland. And the gland is usually a butterfly-shaped gland. It sits right below the Adam's apple or the vocal box right here. It's soft and spongy. If you actually take it out, it's like a fatty sponge, sometimes yellowish to pinkish colored. And a lot of people, when they have problems with the thyroid, well, just take it out. There's a problem with that. Inside the thyroid, there's little glands called parathyroid. And parathyroid basically controls your calcium levels in your body. And so a lot of times when you have a thyroid problem, some people will have calcium issues too that show up depending on what's going on with the thyroid. So it's not just as easy as take it out. So when we're talking about thyroid and not the thyroid, we're typically talking about two hormones. The one hormone is thyroxine, which is T4. It is made in the thyroid gland. We have up here 80%. It's probably more around 92% of what the thyroid makes. And I'm going to go in more to what it is here in a minute. And then T3. And T3 is your usable thyroid. It's what your body uses. Typically, it's more like 5 to 6% in the thyroid. What they're not taking into account here in this study was that your body actually makes T1, T2, T3, T4. So this is T4. And what the 4 represents are the 4 iodines. So you have 4 iodines on here, and that's where you get your T4. When you look at this structure without the iodines on it is called thyroglobulin. And that's what your thyroid makes. And then you stick the iodines on. The glue that holds the iodine on is called TPO, thyroid peroxidase. So that'll come up later on that that's the glue, and I'll remind you of that. But basically, the thyroid makes T4. This is kind of like, if we were going to make an analogy, it's like liquid propane. It's not usable. So liquid propane is not flammable. You can take it down the highway in a truck. It transports down. It's not usable. The second you take off the iodine and make it T3, now it's usable. Whenever you take that liquid propane, you make it gas, it's flammable. So T4 is just a transportation mechanism that works that way. So we get to T3, and T3, if you notice now, we're missing one of the iodines. What this does is this allows it now to plug onto your cell and make your cell function correctly. Your mitochondria, which is your little powerhouse inside the cell, it can plug into it now and make it light up and function and speed up your metabolism. So the difference between transportation and usage is actually that one little iodine in there. So this is a chart I stole from PharmaWiki, like Wikipedia for pharmacists. And this is kind of showing you, this is kind of an overview. This is your thyroid. This is your pituitary gland, and this is your hypothalamus. Your thyroid being down here in your throat, your pituitary is in your brain. And it is actually your master gland. It sends out signals to everything in your body that is a hormone and tells it to put out more hormone, to put out less. So whether it's a sex organ, whether it is your pituitary, whether it's any glands in your body, it kind of gives it the signal. Your hypothalamus is kind of the bridge between your nervous system and your glandular system. So all the nerves come into your hypothalamus, in the middle of your brain. It tells it, hey, I'm anxious, I'm scared, I'm this, I'm that. And all your neurotransmitters plug into it. And it basically tells your pituitary what to do. So if I was going to give this analogy, I would say this is your workers in the factory, your thyroid is. This is your middle management, and this is your CEO up here. So that's the way it works. If you look at these lines on the side, sometimes whenever we have thyroid stuff going on, it goes to the CEO and says, hey, this is what's going on with the thyroid. And the CEO steps in and makes a change. Sometimes it comes up to the middle management and says, hey, this is going on, and it makes a change. This is called a negative feedback loop. So it's constantly coming up and telling what's going on, and that'll be more important later.
But where's the hypothalamus located?
The hypothalamus is located right in the center of the brain.
And the pituitary gland is under that.
The pituitary gland is actually in the front. If you drew a line between your eyes and came in about right here, the pituitary is right there, and it's actually set in a bony. The name is a crypt, or it means crypt. Sulcus. It's set in a bony sulcus, so it's set in a bony little hole in there, is what it is.
Does it have a pineal gland?
Yeah, no, pineal gland is farther back.
In front of?
Yeah, it's in front of the pineal gland. So it's hard to get to, and so a lot of times it has to be operated on, and it's pretty extensive surgery for it. So now, when we're looking at conditions that go with thyroid conditions, we're looking at really four things. We're looking at primary, which means your workers, your thyroid has a problem. We're looking at a secondary issue. Secondary issue means your pituitary or the middle management is basically not producing TSH, which is thyroid stimulating hormone. It tells the thyroid to speed up. Or we're looking at tertiary, that the hypothalamus is not working correctly. That's probably the least likely out of all those to happen. If the hypothalamus has a problem, usually you have bigger problems in life. And then I always say one, quaternary, which is basically there's other issues going on. We have autoimmune situation going on. We have stress situations going on. Medications that are playing havoc with us that come back to the thyroid situation. So the primary and quaternary are probably the two most common issues. The problem is the medical world doesn't look at quaternary very much. So this is another picture to kind of show you just in general that now we have basically our hypothalamus, our pituitary, and our thyroid. And that we can have primary issues, secondary issues, and tertiary issues depending on where the problem is. I'm going to go through each one of those now. So with primary conditions, this is when the thyroid has a problem. We can have one or two problems. It can either put out too much thyroid and be hyper, or too little thyroid and be hypo, low. So whenever we're looking at hypo issues, a lot of times these can be injuries. So there was a group of kids playing like one of them ended up having the thyroid problem because they damaged the thyroid. So the thyroid is like a sponge in there, and you can actually cause damage to it, bruise it up. There's a number of blood vessels that go to it that are extremely important for not only feeding the thyroid, but also taking the hormone and taking it to the rest of the body. So any kind of injury on a steering wheel, choking injury, things like that can cause issues to it. Radiation. So if you have another cancer If your thyroid gets radiated, it's actually very, very sensitive to radiation, and it can have problems. People that were originally working on cell phone towers, they weren't protecting. They weren't shutting down the cell phone towers. They were going up and working on them while they were still hot. All of a sudden, they had huge cancers of testicular cancer and of thyroid cancers because of the radiation. Radar does the same thing to it. So there's significant amount. I still question, in the same time they turned on, the same time we had COVID in 2020, they turned on 5G the exact same month. So in that March is the same month they tied it on. And so we started looking at some of these things, all this long haul COVID stuff. I'm not so sure it didn't have to do with 5G. People here are not suffering from it like people in the cities are, the long haul COVID. So there may be some incidents with that and with trauma to the thyroid. Malnutrition. I could have easily put undernutrition and overnutrition here. Mal means basically it's not correct. So if you put in too much iodine, you have thyroid problems. If you don't have enough, you have thyroid problems. So there's a lot of people out there that if you go online, they tell you, oh, you have a thyroid problem, go take iodine. Not necessarily the case. It can actually mess you up pretty bad if you take it and don't need it. Selenium, same way. Low is bad, high is bad. You need to be right in the right place. Iron, if you're all the way anemic, is a problem, but iron tends to be more of a problem being high. So individuals with hemochromatosis tend to have this, and usually you see hemochromatosis problem in men. So if you see men with hemochromatosis, most likely they're going to be older and have a thyroid problem, and it's not going to be diagnosed properly. So that's an issue. Copper and then vitamin A, B12 methylation. B12 methylation probably doesn't have as much to do with hurting the thyroid as just the thyroid doesn't have the energy to do what it should, and you don't clean out the mitochondria so it can plug into it and make it work. So that's where the B12 plays a role in here. And then vitamin D has to do with transport for it. I will tell you, if you have a thyroid condition, if you go and get sunlight, your thyroid numbers come up, you feel much better. And so even the vitamin D that you take from the store, even the best brand you get, doesn't do the same as sunlight. And so I think what they're going to find is someday there's going to be a vitamin Z there or something like that. And they're going to find out that the sun gives you something totally different than we know of right now. So it's a thyroid surgery. So people have it removed. People have had radioactive iodine. That's a given. The radiation again. Medications. So there's a number of people who are getting antivirals online and stuff to take because of COVID and the bird flu and all that. A lot of these antivirals will mess up the thyroid pretty quickly. So you got to be careful with it. Lithium, so for bipolar disorder, a lot of those individuals will become so lethargic and they think, well, it's just the medications they're on. Well, they're lethargic because they shut down their thyroid there. So big deal there. Postpartum. So your thyroid is doing everything it can to keep the baby alive, keep it going, and all of a sudden you have the baby and your body tries to regulate, and so it goes up and down until it regulates. Usually that self-regulates out of itself. I mentioned hemochromatosis with iron. Amyloidosis also is a protein that builds up in some individuals that has a problem. And then you can have birth defects and have thyroid problems. Some of these babies that have birth defects, they will be enlarged when they come out. You'll see a larger baby, and you want to come in and check immediately for thyroid function in those babies. Either mom had too low or the baby's not producing. Yes, sir.
Could you repeat the part about the zinc up there?
Yeah. Zinc in particular, too little or too much can cause a problem. Too much zinc in particular is really, really bad for you. So during COVID, I told the story back, I think one of the first classes I did. During COVID, I had people coming in and they were starting to get neuropathy. They couldn't feel their hands. They couldn't feel their feet. They just weren't feeling right. They were lethargic. Anyway, I'd go through everything and finally they would have zinc down as what they were taking zinc. And they didn't have an amount. And I said, so how much zinc are you taking? I don't know, maybe 10 to 20 things a day. So you're doing what? Yeah, we have a candy dish at work and we just pop one every time I come past it. And so zinc, if you get above 80 milligrams a day, it starts basically short-circuiting you because it's a metal and your body's electric and it starts short-circuiting it. Same thing happens with the hypothalamus.
How much do you need?
You need between 50 and 80 milligrams a day is about how much you need. You can actually, I should say between 30 and 80. I would say people here probably have a little more zinc because people eat a little more vegetables. A lot of your root tubers, things like that, you pull them up. So any of your minerals, you like them in sweet potatoes, any root tubers, things like that. So usually have more of them. So no, nickel's yeah, nickel's present in it. So are your bad things too, your arsenic and all those things in there. Yeah. Usually it's not, nickel's not in a high concentration in the ground, because usually if nickel's too high, you don't grow very good produce. So you're usually getting nickel from groundwater, from things like that, from contamination. So yeah. Did that answer your question?
Yes, thank you.
Good. Okay. So, things that cause hyper, most of these are going to be inflammatory responses that cause hyper. So you can have an individual who gets a virus, and this is probably, in my opinion, the number one cause for hyper is a virus. And usually you'll see this in younger people. They first go right when they're going to college, something like that. They get exposed to something, they catch a virus, and all of a sudden they start losing weight. They're having anxiety attacks, they're having panic attacks. They come back home from college, and you're like, are you eating? They're like, yeah, I'm eating everything. And we go and we see it. That virus, a lot of times, will actually then trigger an autoimmune type response and cause these problems. And then the bottom one down here is excessive iodine. So if we see this show up in older people, it's almost always that they've been taking iodine for 2 or 3 years and they're cranking in like crazy. Or they're taking multiple vitamins that are full of iodine and they're getting a lot of it. So, and then postpartum thyroiditis, and that one usually is short-lived and then goes away. It's kind of just like it was. That when you have the baby, it goes up and down until it regulates. Your immune system does the same thing after you've had a baby. And then the painless thyroiditis usually is a problem with the hypothalamus, and they just misdiagnose it here. It falls in just because of the way it tests out. They miss it. So how do we test for these primary conditions? Basically, the old standard that they do at the doctor's office. They're going to run a TSH, thyroid stimulating hormone. If it's up, basically it says you need more thyroid, so they're going to give you thyroid medication. If it's down, most of the doctors even say, oh, that's great. If it's down, typically you have hyperthyroid and they're never checking into it. So you could have a problem, but the only thing most medical world does is give you thyroid medication when they see TSH up. So now, how do we treat primary thyroid disease? A lot of times it's with medication or with glandulars. If it's just mild, we can give you a glandular, usually a porcine thyroid supplement. We use standard process a lot of times, and it actually works well if the numbers aren't bad. It actually works incredibly well. If we're having actually high thyroid, they come in and take it out. They can do surgery to do it, or if you have a tumor in there, they can do radioactive iodine. So they can get rid of it. I don't know why I have radiation damage, but you can damage it with the radiation and get rid of it there. You can supplement the nutritional deficiencies. So if we're having an iodine issue, if we're having an iron issue, we either put it in or take it out. We change or eliminate the medications. So even today, I was working on a case where an individual has diabetes and they're eating perfect. Theirs is a medication issue. So a lot of times medications will show up and you'd never suspect that it causes something way far different, but it happens quite often. Postpartum, we usually wait and see what happens, see if it resolves. It will often be treated by doctors. People come in 2 or 3 months after they've had a baby, and the doctor says, oh, your thyroid's low, put you on thyroid. And all of a sudden, well, they're tired because they're up all night long, breastfeeding and all that. Put them on thyroid. All of a sudden, a month later, they're having anxiety attacks, they're having panic attacks because their thyroid switched back into normal mode, and now it's too high. So if it's ever postpartum thyroiditis, they should probably be checked every 4 weeks until it stabilizes. And then treat underlying conditions. So whether it's hemochromatosis, amyloidosis, something that's causing that, we do that.
Did you already say what is hemochromatosis?
I mentioned I didn't say what it was. Hemochromatosis is a genetic condition that makes you hold on to too much iron. So your liver, you don't excrete any iron, you hold on to every bit of it, and so it just keeps going up and up and up. Typically, you see it in guys. I have that gene, so I go and give blood every, 2 months or whatever they let me give blood, and my levels stay perfect. When I don't give blood, I can tell all of a sudden my levels get high. Particularly in guys, they'll be a little more ornery because it causes some damage to the liver, and liver stuff causes you to be ornery. You tend to have not as good a vision. Women tend to be a little low on iron anyway, so when they have hemochromatosis, up until later in menopause, they tend to be normal levels, and then later in menopause, you get the crabby old lady. It's because all of a sudden her iron got high because she's not losing anywhere, problems like that, and so you treat her, you say, okay, let's go give some blood when you get to that stage. So sometimes that's what happens. Yeah, amyloidosis is a protein that builds up. It's a genetic condition too, so both those are genetic-wise. Secondary conditions. So now we're looking at pituitary issues. Either we have decreased TSH causing hypothyroid or increased TSH causing hyper. So we go back to this picture again. This was primary, our worker, and it produces T4, makes T3. In this case, now we're going to come up here and see what the pituitary is telling. And the pituitary's main signal is TSH, thyroid stimulating hormone. It basically tells the thyroid what to do. When we have secondary conditions, the problem is here. So secondary conditions, similar to primary, but the problem instead of being with the thyroid is with the pituitary. So the first thing we can have pituitary tumors. Actually, when you look at MRIs and CAT scans, a number of people have pituitary tumors. They're very small, they're very mild, and so we never know anything about it. Maybe they have a situation where as they get into their 30s, 40s, 50s, they don't produce enough LH or FSH, so they're not producing testosterone, estrogen, and so they go in, they basically test them out, say, oh yeah, your testosterone is low, oh your estrogen is low, and we give them estrogen and testosterone. We don't realize that that's a problem.
So where the pituitary gland is tied in with hormones?
Yeah, every hormone. It's the one that makes it's your middle level manager. It makes all your hormones that tell your other glands what to do. So, for instance, LH and FSH are the hormones that it produces to tell your ovaries what to do. In a male, they tell the testicles what to do. It has your growth hormone. It produces growth hormone that tells you to get bigger or stop growing. So it's your master hormone or your master gland making your master hormones.
So would you say all hormones come from the pituitary gland?
Oh, no, because it's your master, so it sends a signal down to your other glands then that make the hormones. So let's take testosterone. So your pituitary gland will make LH. That goes down to your testicles and tells it to basically start making sperm, which then begin to start making testosterone. So it's your master one. It makes all your master hormones, but then each gland makes their own.
Their own individual additional.
Right. So every gland in your body has to get a signal to make what it's going to make. So your adrenals have to get ACTH from pituitary gland to tell it to make adrenals. So a lot of times we're looking at adrenal issues and it's a pituitary issue. So this is actually a good point. So let me see if I can back up one. This same picture we have right here, you could put any gland in this position. In every gland we do. So whether this is an ovary, whether it's a testicle, whether this is a adrenal gland, whether this is even saliva glands, whether this is the glands that produce acid in your stomach, we could put them all here because we could line up all your workers here. This is just one of the workers. This is still the manager over all those workers. Your hypothalamus is still always going to be the one that takes the neurotransmitters and says, okay, this is what the neurotransmitters tell me, this is what the brain's telling me. Okay, now, pituitary, this is what the outside world's telling me, here's what you need to do. And the pituitary says, okay, let me first see what all my workers are saying. Okay, yeah, what you're telling me is right, I'll do it. That's the way it works.
Okay, and did you one time say that the nervous system communicating with the brain is really more of a system up than a system down? And I think you said to the extent of 80-20.
It's exactly that way. So let's say we're gonna block this off. Let's say this is the nervous system coming up. Okay, these are nerves coming up to the brain. That's not this case, and for this drawing for thyroid, It's not. But in the world, what I'm telling you, this would be your vagus nerve coming up from your stomach, coming up from your digestive tract. It comes up and it feeds into your hypothalamus. Then your hypothalamus may send back some nervous system signals, but it's very few. It actually comes up to the hypothalamus and says, okay, now let's tell the pituitary what's going on in the stomach and go out. So the hypothalamus, most of it's done through secreting of signals to the pituitary. It has some that goes back out through the nervous system. So the 80-20 is right. On the nervous system side, it communicates out another way also. Perfect. Yeah. So this would be your CEO picking up the phone and calling the pituitary and saying what we need to do. This would be hallway chatter coming up to it all the time. And the CEO is walking down the hallway and he's listening to the chatter, but he doesn't stop and talk to the people at the water can. He's just listening to them. Then he picks up the phone and calls the middle management and says, hey, I just heard this in the hallway. You need to take care of it. Now, once in a while, the CEO walks down the hallway and he hears something at the water cooler. He goes, oh, hey, tell me what's going on. You know, this is what I think about that. But most of the time, he's not going to mess with it. He's going to go call the middle management. So that's the way that works. So, pituitary issues. The tumors in there, usually they're benign. The problem is that sets in the sulcus in there, which is a little cage made out of bone. It's inside your skull. And if you get a tumor on the pituitary, it's really benign. It's not a problem. It's kind of like a mole on your skin. The problem is there's only so much space in there. So if you get a tumor in there and it starts to get too big, it squishes the pituitary where it can't do its job anymore. So that's when you got to go in and take it out. And I've had a number of patients that have had that done. But usually pretty rare. And if you do see them, most of the time you monitor it until it has to come out. So if you actually look at MRIs, CAT scans, you see more than you'd ever think you would see if you actually look for it. Pituitary gland damage. So this has to do a lot of your football players, a lot of your hockey players, people that have had major concussion time after time after time. That is such a tight little space and it gets rattled around. It gets bruised up, blood flow stops to it, and you stop producing. So you see a lot of football players and stuff having all kinds of issues because of the brain damage, and it goes back to they got beat up. Ischemia. So strokes, lack of blood flow. A lot of individuals, as you get older, you get ischemia, you get small vessel disease in your brain. There's almost nobody I look at over 60 or 65 that the blood vessels in your brains don't get smaller. Well, you don't get as much blood flow to the pituitary or the thyroid or the hypothalamus. You start having problems. Sheehan syndrome, that's actually a birth, you get squeezed in the birth canal or you go without oxygen for a while and you have some issues there. And then radiation again. Radiation therapy for breast cancer, again, cell phone towers, things like that can mess this up. And then now it actually changes from being amyloidosis to sarcoidosis can cause a problem. So people that have sarcoidosis tend to start having hormone problems after a while. And then again, hemochromatosis becomes a problem. The nutrition deficiencies change a little bit here. So iodine is really not a problem so much in the pituitary. It's a problem in the thyroid and a problem in the hypothalamus, but not here. So zinc, iron, vitamin A, methyl B12, cobalamin. In the pituitary, it becomes a problem whenever people go and get real cheap vitamin B12, and I've seen this a lot in the last 2 weeks. People come in and their vitamin B levels are really high, but I'm examining them and it looks like their vitamin B levels are super low. Their tongue's all cracked up. They're having all kinds of B vitamin issues. And so I go back and I say, can you tell me what brand you're taking? And we look and see, and a lot of them are on Now brand, which is our Nature's Choice, I think it is, at Walmart. They use cyanocobalamin instead of methylcobalamin. So basically, cobalamin is a B12, and the whole function of B12 is to carry a methyl group to your cells, to everything to make it work. Well, cyanocobalamin is cyanide and B12 fastened together. It is dirt cheap. If you ever get a cheap B12 vitamin, look at it. It's going to be cyanocobalamin. So basically, it's carrying a cyanide group in your body. It has to drop it off, then go around, find a methyl group, pick it up, and then take it to your cells. It's not very good at doing that. Once it tends to drop its payload, you pee it out. So basically, when you're taking cyanocobalamin, you're putting cyanide in your body, dropping it in your body, and then peeing out the rest of it. And so it's a really big, bad deal. but it's super cheap. So price-wise, methylcobalamin is about 10 to 20 times more expensive than cyanocobalamin. But one's poison and one's good for you. So big difference there. B6 and vitamin D again. Vitamin D does have an upper limit. So some people come in and actually overdose on it. You want to keep it, basically when you do a blood test, under 100. When you get it over 100, you start pulling calcium out of the bones, and you start putting it in places you don't want it. Kidney stones, in your muscles, things like that. If you don't have enough, you also do the same thing. You put it in bones. So you want to keep in between 50 and 100 there. And then certain medications, again, mess up the pituitary. Now, this is pretty significant. Probably out of the first slide that I say, okay, this is important. Now, the medical world runs a TSH on you. That's what standard of care is TSH. If you look at this, I can have hypoprimary, or I can shift over here and I can have hyperpituitary enhancement. And so basically, if I saw this and all I looked at was a TSH, I would treat you the same way. I'd give you basically thyroid medication here, and I'd also give you thyroid medication here. But you shouldn't have thyroid medication in both of them. So it's interesting because I would say probably 50% of doctors don't run anything else to treat thyroid other than this. And thyroid, even if you're taking thyroid medication, your thyroid is not the same all the time. It changes. It may be a year, maybe 2 years, but it will change. And so that's why this kind of testing doesn't work well for people who are taking thyroid medication. It's a good line of defense, but it's not very good in the end of it. So why is TSH the most tested and frequently only tested thyroid medication? The reason is it's dirt cheap. It's really cheap to run. Most of the time in a hospital laboratory, it takes about $1 to run it. So you may pay $10, $20, $30 for it, but it costs about $1 to run, and so it's cheap. Insurance companies basically tell doctors what they do now. And so it's called medical necessity. If I was a doctor taking insurance and I ran other tests too often, I would get a letter from the insurance company and saying, you are not doing this based on medical necessity. There's no reason for you to do this. Do not do medical necessity. And basically, I'm going to deduct your pay. So if they were paying me $30 an office visit, they deduct $25. I do it a couple more times, and after a while, they say, you know what? You're still not following our rules. We're going to lower your pay. So a lot of doctors will look at this and say, you know what? It's not medically necessary. Well, who told you that? Well, the insurance company told me that. Well, okay. So that's why. So now, what tests are available to test this thyroid cycle here? There's a lot of tests, actually. There is one to test the hypothalamus. Basically, it's TRH, and it tests whether the hypothalamus is producing thyroid releasing hormone. It's basically that phone call from the CEO to the pituitary. That one is rarely ran because you can usually figure it out other ways, but it's out there available. The first one that we just talked about, TSH, thyroid stimulating hormone, it's produced by the pituitary. It signals the thyroid to release T4. So that's the one, whenever the manager calls the workers and tells them what to do, that's TSH. Your thyroid produces T4. That's the total amount of thyroxine in your blood when you do this test, both free and bound up. So it's just total amount that's in there. Total T3 measures the amount of T3 that's in your blood, including that's stuck to tissues and loose. Then you get these tests called free T4 and free T3. Basically, those are the only ones that are floating around in your blood. And so sometimes those are more significant. The total is significant. Each one plays its own role. Then we have a reverse T3. Whenever I showed you T3 and it had 3 iodine on it, well, ever so often, the wrong iodine gets pulled off. When the wrong iodine gets pulled off, it can't plug into your cell anymore and be used. So basically, it gets pulled off and it's floating around and it says, hey, I want to work for you, but it can't. And so it becomes a problem. So too much T3, we have to see that sometimes. T3 uptake is basically, the best way to describe this is kind of like a dipstick in your car. You basically take your dipstick, you stick it down and you see how much oil is there. This test just basically is a stick that you dip in there, and it basically tests how much T3 you have and how much is available to be used up correctly. So then there's another page of thyroid tests. This is basically the binding sites for T4. So on the outside of your cell, there's sites that T4 comes up and touches, and the cell pulls in the T4 and then pulls off the T3. This is the site on the outside of your cell that the T4 sticks to. And it's significant. If you go give somebody too much T3 or T4 in medication, this number will start to drop. And it does it on purpose to protect you from revving up your cells too much. If you get hyperthyroid, it will try to start shutting these down the best it can to the point that your cell starts to die and it says, okay, we can't shut this down more. But it is a negative feedback loop. So it's like kind of like I Love Lucy. They're standing there at the chocolate factory and things start going through, and at some point she starts shoving them in her mouth. Well, finally somebody goes over and turns down the volume on the speed. This turns down the volume on the speed is basically what it does. Thyroid peroxidase antibody. Remember, I said TPO is the glue that holds your iodine to your thyroxine. So this is the one that holds the iodine to it. This is significant. The reason this is significant, and I may not be able to get to it a whole lot tonight, but TPO antibody can't tell the difference between gluten, TPO, coffee, a couple other things in your body. So individuals that end up getting a gluten sensitivity will almost likely end up with a TPO antibody and vice versa. If you end up with a TPO antibody, you'll have a gluten sensitivity because the body cannot tell the two apart. It can't tell TPO and glutein 14 and 17 apart. So once you get this, if you keep eating gluten, basically this number goes up, and as that number goes up, it actually comes in, puts a little flag all over your thyroid, and you start destroying your thyroid. So at first, your thyroid tries to speed up because it's under attack. It starts to speed up. It's trying to do its job better. Well, then it gets tired and it drops. So a lot of times you'll see these people actually go hyperthyroid for a short time period, very short, and they're like, oh, you know, when I was in my 30s, I was thin. I had all the energy in the world. It's because your thyroid was overactive. And then all of a sudden, you got too high and it crashed. And a lot of times it can be because you're still eating gluten or that you had dairy in there or something that it cross-reacted with and it caused the problem. I've had young ladies come in that we catch this early. So we're talking college-age ladies. We catch it early, and now 10, 15 years later, their thyroid is perfect, but they took out gluten or they took out dairy, whatever the offending factor was, and they didn't have the problem. Thyroglobulin antibody, very similar, but instead of being to the glue that holds the iodine on, this is actually to the body, to the thyroglobulin right there. Then we have a thyroid stimulating immunoglobulin. And so basically to that stimulating, the TSH, this is an antibody to TSH. So when your pituitary is sending the signal out, it attacks that signal. And then thyroid blocking immunoglobulin, this is an antibody against basically the receptor sites in the thyroid where the TSH plugs in at. It basically attacks that. And so the TSH, your pituitary can be saying, hey, what is this? Somebody's cut the phone line. It can't plug in there, is the way it works. So now, I showed you a while ago that we couldn't tell the difference on the primary and secondary if we only ran TSH. So you can't tell the difference between them. The second we come in and throw in a T3 and a T4, now you can see, okay, I have a high TSH. Well, okay, this is low and this is low. Oh, I have a primary hypothyroid problem. But let's say I come across here, TSH is high. Okay, I have high, but I also have high T4, high T3. I got a pituitary problem going on. That's significant. So that's how we start to tell where the problem is. So we go a little farther than saying, oh, you have a thyroid problem. You have a thyroid problem, but it's actually caused by a pituitary problem. And that was simply by adding those two of the tests in, and it makes a huge difference in the outcomes in the end. So further testing we would do if we saw that then. So let's say I just ran the T3 or TSH, T3, T4. I would come back in and I'd say, okay, this is a secondary problem. Let's run some growth hormone. Let's run the TSH again. Let's run the ACTH. These are all things that are produced by the pituitary. So when, I forget your name, I'm sorry, but
Oh, Josie.
Josie, that's fine. I'm sorry. Anyway, when you asked me a while ago about the pituitary, these are different hormones that it sends out to every part of your body, telling it. So these here are going to go to the gonads. This is going to go for muscles and for milk production. This is going to go for your adrenals. This is going to your thyroid. This is going to every cell in your body, telling it to speed up and to grow bigger. So
the master hormones that come from.
Yeah. There's a few others, but these are the cheap ones to test. So if I was suspecting that you had a secondary thyroid issue, and I'm suspecting that's a pituitary issue, then I would test these to see what else is going on. And if these all come back goofy or messed up, then I know, okay, we need to go order an MRI or a CAT scan to start looking at the pituitary and see if we got a problem there. So that's what's going on there. So how do we treat this? Sometimes you say, okay, yep, we got a problem here in the pituitary, but we're not going to be able to touch it or change it. So we come in, we still medicate it, or we use glandular stuff. We look at the nutritional defects there. Sometimes they're pretty easy to find. Sometimes we change or eliminate medications again. So a lot of our psych drugs will start playing havoc with it because they mess up the adrenals. And when I showed you that picture a while ago that came up, back up, it'll mess up from that way and come back up. And then we can do surgery to remove the tumors and the pressure there. So now tertiary conditions. This is the hypothalamus issues. It can be producing too much thyroid releasing hormone or too little thyroid releasing hormone depending on the situation. So now we're talking to the big boss. He's having problems. We got to figure out what's going on up here when he has problems. So when we look at that, what kind of things do we have here? We can have a hypothalamus tumor. I'm going to say this. You pretty much know it if you have a hypothalamus tumor. A lot of times it'll be onset looking like dementia to begin with, and then it starts looking like Parkinson's disease. Then you start having blindness. You start having a whole bunch of things. The hypothalamus, when you dissect the brain, it looks like a little brain inside the brain. And that's exactly what it is. It's a little master. It's actually the really smart part of the brain. The part that everything happens in your body automatically, that you don't have to think about, it's done by the hypothalamus. So
It's the center of the autonomic nervous system.
Exactly. So your vagus nerve really plugs into it. All of your surrounding mind. So when you look at, I don't want to say monkey brain, but when you look at a reptile brain, basically they don't have the huge cortex, this blue part around it. They have very small cortex, but they have a hypothalamus about the same size as ours. So we have our little bitty brain inside of our big brain, and that's the master autonomic nervous system. So that's perfect. So, pituitary gland issues, and by the way, that shouldn't say pituitary there. That should say hypothalamus. Hypothalamus gland damage. So anytime you have a head injury, you have a stroke, that Sheehan's syndrome again, radiation there. So you can kind of see the common themes here every time, but it just matters where the damage occurred at, is what's going on. Nutrition. The nutrition changed again. So particularly zinc. And if you get too much zinc here, it really messes this up. That's why people were getting the numbness and tingling and stuff when they were coming to my office when they had too much zinc, because they were really messing up the autonomic nervous system. Iodine. There's the name for this condition when you get too much iodine in the hypothalamus is called Wolff-Eckloff, I think is what it is. Eckloff syndrome. And basically, it took a long time for them to figure it out. And they finally figured, these people have too much iodine. It's causing a problem with the hypothalamus and that. And then vitamin B6 deficiency in particular will cause a big problem here. Vitamin B6 in autism is a big deal. Vitamin B6 plays a role with interleukin 6. And so a lot of times kids that have, they're born with sensitivities, they're born with allergies, they're born with a virus, something like that. They use up B6 rather quickly. B6 works with mast cells. And so when that gets off, a lot of times you'll see interleukin 6 really high and it causes some damage. And basically B6 helps relieve that. So that's some things in there that we look at. And then medications, in particular steroids. Steroids mess up the hypothalamus. So you get people that they're like, well, yeah, I've been on prednisone all my life. You're going to have a hypothalamus problem somewhere along the way. It's set up to it. The hypothalamus, when it's getting the signal from the worker, which is basically the adrenal gland in this situation, it keeps sending a signal up and it says, we're being overworked, we're being overworked, we're being overworked, being overworked. And finally the hypothalamus says, okay, hit the master switch, we're shutting everything down. And it starts shutting down all the hormones and stuff. And so you'll see these individuals are the people that have been on steroids, from the time they were 20 or 30, probably because they had an autoimmune disease and they didn't figure out what the underlying problem was. So they just put it on. All of a sudden they're 45, 50, and you'd think they're 85 years old. And that's that person. Dopamine antagonists. A lot of times we'll see things like this with Parkinson's disease, things like that. And they're trying to shut down the system so that you're not shaking and stuff. And basically they're shutting down the system. They're shutting down the hypothalamus in this situation. And then somatostatins, these are basically ones that work to shut down hormones and things like that. So we'll see this. Sometimes they'll give this in, if I'm correct on this, I may be wrong on this, but they will give this to people that have severe PCOS, things like that, to kind of try to shut down all the hormones. They're going to the master and saying, shut it down. How do we test for tertiary conditions? So now, if you look again, we can do these three things and we can quickly figure out if we have a tertiary condition. So basically, the top one up here, TRH, is not done often, but if we think we have a tertiary and we want to confirm it for sure, we do it. It's a little rougher. They actually give you an IV and then come back and measure your response to the IV. They basically give you TRH and see if you actually respond to it and see if it's a problem. So that test is an expensive one, and typically you can figure this out without that test, just by looking at it. We come in, we're looking for, and you'll have other symptoms. So if we came in and we start measuring pituitary, and remember we have all those tests in pituitary, and they get crazy, then everything else, if we rule out pituitary and say pituitary is not a problem, and we have this same setup, then we come in, we have to rule out hypothalamus. And we would run some tests to do that. So, quaternary conditions. This is probably what we see the most of typically. So probably primary conditions are the most caught because they only run the TSH and they catch it most often. The secondary and tertiary are the most missed on it probably all along the way. These here are probably the most common and the most undiagnosed. Whenever we get to this, we're looking at autoimmune thyroid disease. And this is where, like I said, probably 80% of the thyroid conditions I see in here that are missed are usually an autoimmune disease. So now again, we're looking at that TPO antibody, we're looking at the thyroglobulin antibody, we're looking at some of the receptor site antibodies, things like that. Food sensitivities. So food sensitivities, like I just said, gluten, casein or dairy, can very quickly cause a problem with the thyroid gland. And it looks goofy. They try to medicate you. It goes up and down and you can't figure it out. It's because, well, one time you're eating a bunch of bonbons and then you don't eat them for a while and the holiday changed and then you go on this really nice diet. And so they tend to be missed a lot unless you run those thyroid antibodies. Mitochondrial dysfunction and oxidative stress. This is probably the least understood by the medical world because they see a cell as a cell and that's all they see. But inside the cell is a whole other world going on. You have mitochondria in there, which are your powerhouse. You have Golgi bodies that are packaging goods, taking them out, getting rid of them. You have the DNA in there that's replicating, and it's usually overlooked. Mitochondria are the powerhouse inside your cell. That is where most of your T3 plugs into. So the T4 comes up, it bumps into your cell steps and says, okay, come on in. Comes in, it pulls off the iodine. That iodine goes to your Golgi apparatus in there, which is your packaging, to send it out of the cell. Then T3 gets up against your mitochondria and it speeds it up. And it tells it, okay, speed up, come on, keep going, keep going. Well, that's all fine and dandy, unless it gets sped up too fast. So your car, if you start putting gasoline in your car, it does pretty good. If you open up the governor and you run it full throttle, it starts to burn up. Your car doesn't last as many miles. That's what's happening here. One of the biggest offenders in this situation is sugar. So when you speed up that mitochondria fast and you're feeding it too much sugar, it builds up toxins inside. It's actually oxidative stress, which means rust. That's what oxidative stress means. So these mitochondria get rust in them. Well, the mitochondria is trying to get rid of the iodine. It's trying to get rid of all the exhaust. It's kind of like your catalytic converter. It's packing up. It's getting rid of it. Well, when the thyroid is too high or sugar's too high, those two things cause this oxidative stress. And it causes it to happen really quickly. Once you get so much oxidative stress, the mitochondria sends a signal out, and that signal goes straight up to the boss man, to the CEO, and says, we have too much stuff going on here. We're failing our back to Lucille Ball and that, and all the chocolates coming through. We have a problem. Flip the switch, flip switch. And after a while, it says, okay, we're shutting down the switches. So then all those receptor sites everywhere just start shutting down, and you have a problem here. So sugar, stress, things like that play a big role here. Toxins. So you saw me mention iron. You saw me mention zinc a while ago. Those your body needs to produce certain functions, but then there's other things, mercury, lead, things like that, that begin to throw a monkey wrench in all the signaling. So your body, even hormones, when they plug into something, they send a little electrical signal to it and tell it what to do. So it may be floating along as a chemical, but once it touches, there's an energy process that goes on there. Well, when you have too many toxins, and typically toxins have a metal in them, and when they get in the way, so let's say I'm going to come up here and let's say I'm going to shake your hand. So put your hand out there. I'm going to shake your hand. And I come in here and there's something in the way. It doesn't work right. And that's what those toxins do. They make it so we can't get the signals to the cells, and it makes a big difference. Mycotoxins. Myco means fungus. And so this, I honestly don't see out here in Wyoming as much as I saw in Missouri. Fungus, there's still people with fungus. Usually they have too much sugar. There's some things going on that once you get fungus started, your body tends to propagate it easier, and that's because of mycotoxins. Mycotoxins are what breaks down. If you get mushrooms growing on a log, they break it down. Well, mycotoxins in your body start to break down stuff. Well, you can see if you get one mushroom on a log and it starts to break down a log, you can get a bunch of mushrooms on there real easy. Fungus is the same way. You get a little bit, and people are like, oh, I just have a little bit on my toenail. Not a big deal. Or I have a little bit here. Oh, yeah, I'm not worried about it. Yeah, that little bit doesn't take long before it becomes big. So we always clean up toxins or mycotox really quick and fungus really quick. I started to put diabetes right up with mitochondrial dysfunction, but it comes down to if your sugar is high, you're going to have, there's a number of problems, but probably the problem starts with mitochondrial dysfunction. It starts with whatever else you're putting it in, and sugar attaches to it. Sugar attaches to things real easy and speeds up things. Infections. We talked about when it came to the thyroid that individuals can have hyperthyroid with infections, but other infections start damaging this whole system too. And sometimes we get infections that your body thinks are the thyroid. So let's say you get a sore throat, strep throat. That strep throat is just a couple layers away from the thyroid. So you get it in there, you kind of get a sore throat, you're hacking, you're coughing, a couple cells get damaged, all of a sudden it gets through, gets in the thyroid, and now you got it there. Viral infections do the same thing. And then organ damage. And in particular here, we're not talking about thyroid because we're talking about coronary situation. This is, you get kidney damage. You get something like that. Well, if the kidney's trying to heal itself, it's been damaged, it's trying to heal itself, you've had a surgery, it's trying to heal itself, well, your body says, hey, it can't do anything more right now, it needs a little break. So it sends up that signal to the hypothalamus and says, your kidney needs a break. Let's shut down this thyroid a little bit. And so it'll make that thyroid drop. So you'll see a lot of individuals, if they've been really sick, whether they have a liver problem, whether they've had surgeries and things, their thyroid will intentionally drop down as a protective mechanism. And it should. The catch is, it should come back up. So sometimes doctors make a mistake in this situation, is they come in and try to give you thyroid. Oh yeah, you're in the hospital. We did your blood work. Your thyroid's low. We're going to crank up your thyroid. Well, hey, you just had surgery, here, a month ago? Well, you're still in that 8-week range where you're still healing up, and now you revved it back up. It doesn't help your body heal. So sometimes you got to say, yep, that number's off. It's okay. Let's wait and come back and take a look at it. And I think sometimes patients hate that when I tell them that. I say, let's come back in 2 months. Well, either they don't want to spend the money, which I understand, or they're like, well, just get it done. No, your body's doing what it should be. So we got to pay attention to that. Stress. So the stress I almost put straight in with the hypothalamus one because it basically does two things. It makes your corticosteroids go up, which makes your hypothalamus go down. But also stress with your vagus nerve again sends a signal straight to your brain. It says, speed up everything. And then it says at some point, it says, hold on, we can't speed up everything because now we got too much waste here. So slow it back down. And so stress can, a lot of times people when they have stress to begin with, their health will go, and that's what's going on. And then finally it gets to the point where the hypothalamus says, I am done. We can't take this anymore. And you crash. And so that's a real thing there. And then lack of sleep. This lack of sleep is an interesting one. Lack of sleep, basically, I think that may be on one of the, right here. So these are things that plug into here, plug into the hypothalamus. So these are almost your quaternary ones when you look at up here. Severe stress, circadian rhythm, which is your sleep. People that work split shifts and change all the time, they have thyroid problems. And especially when they get older. My mother and father-in-law both work split shifts in factories all the time, both on thyroid medication. It's pretty bad. And so you see it. And then acute psychosis, which I think can really play a role over stress, but probably the acute psychosis has to do more with the medications they gave them. So your medications are to dumb down or bring up your nervous system, or sometimes they give you both of them. And the hypothalamus is getting these signals and it says, I don't know what to do. And the hypothalamus and your whole nervous system, all your glandular system, when it doesn't know what to do, it doesn't waste the energy. So it's kind of like the parent or somebody that gives up on somebody. You're kind of like going, okay, I have done everything. I've given you all the money I can. I've hauled you here. I've done this here. I've done this here. I give up. That's exactly what happens with that when you start throwing too many psych meds in there. And then actually cold, if you get really cold, it speeds up the hypothalamus. So all of you have heard about the cold plunge and doing that kind of stuff. In the right circumstance, the cold plunge can actually restart this system. So Dr. Gary Brecka does a lot on cold plunge, and it's kind of the big thing right now. There's a few people that shouldn't do that, but in general, the cold plunge for a few minutes actually does really good for this.
So you recommend cold plunges?
Yeah. I think you need to cycle on and off of it. So my research I've done, cold plunge after 30-some days of doing it loses all of its effect, doesn't work anymore. So basically, we always talk about that negative feedback loop that comes up and reads it. After a while, it says, I don't know why you're doing this. I'm going to stop listening to you. So literally, you go a cold shower. You take the shower from hot, turn on to cold for anywhere from 30 seconds to 6 minutes, and it lights that up. But after 30 days, you quit for a week, and you do it again, and it lights back up the system. So it's kind of like a master reset for the hypothalamus and the vagus nerve. So it seems to be pretty effective. Yes, sir.
Does your sleep cycles kind of repair itself when you stop that shift work or that split stuff?
Yeah, it just depends how long you've done it. It's tough, especially like if you're ENT, fire guys and everything. You've taken a hit with that from a corticosteroid issue because of the stress and the sleep and all those. And so it's a matter of really being diligent now and saying, okay, I'm going to calm this system down, and not getting riled up and not doing that kind of stuff and just intentionally calming it down. I kind of say it's jokingly, but it's actually a true thing. We're still primitive man. And so when you feel stress coming on, if you go out and walk outside and you look for a little daisy in the street or the dandelion, you look at the grass there and you look around and you're actually looking at stuff, your brain thinks, oh, I'm foraging. I'm not running from anybody. I'm not stressed out. And actually your whole psyche changes by literally going out and smelling the roses. It makes a difference. Yeah. Breathing, belly breathing also changes that cycle too. So, stress, circadian rhythm, all that. When you're breathing up top, basically that's a sympathetic nervous system. It says, you're scared. There's a problem here. I don't know what's going on. The second you change that to belly breathing, basically, and you can even hear my voice, it changed, I didn't intentionally change it, but it changed. It basically says, okay, it's time to rest, digest, and heal. Nice. It changes the world once you get used to it. Change your walk so you get strengthen your booty, you get that breathing down. That's the two exercises that change your world. Okay. So autoimmune thyroid diseases. When we're looking at this, we have Hashimoto's. It was named after a doctor, Hashimoto, and he found that people that tend to have these antibodies tend to have lower thyroid. One of the things that he didn't know in his time, because they were catching it after they had these symptoms, but typically you get these antibodies and they make the thyroid speed up like I talked earlier. So a lot of these people, when they're in their, let's say, teens to 30s, they start getting this antibody and literally they're eating the kitchen table and everything else. They're not gaining weight. They have all the energy in the world and life is great. And then after a while, the thyroid says, I can't keep up with this antibody. It's destroying me. I'm just going to shut this down. And all of a sudden you go into low thyroid. And then if you have a good doctor, they catch it. The catches early on individuals. And a lot of times, to catch it early, you look at their throat. If you see somebody in their 20s, 30s, and they're swollen right through here, so they kind of come down, they dip in, and then all of a sudden they come back out, and then they dip in again, their thyroid's swollen, and they have a thyroid antibody. It's called a goiter, is what it's called. So if you've heard of a goiter, you'll see it. And if you look around, you will notice it. It's there. Graves' disease tends to be hyperthyroid. So these are individuals that their thyroid's gotten too high. A lot of times, with the top ones, you will go to Graves, and Graves turns into hypo. And so you tend to go Graves to Hashimoto's. So they are a different set of antibodies, and usually these are not tested right off the bat because you usually know you have Graves. But if people are having thyroid problems, they're bumping up and down, they can't figure it out, we run these tests and we're like, yep, you're having a thyroid storm, this is Graves' disease, and we either need to calm it down with some medications, or they go in and they irradiate thyroid or do thyroidectomy, take it out, depending on what's going on. So this is a more extensive chart of testing. And so a lot of times you can come in, you can look at this, and you'll say, okay, when I run thyroid, just a general thyroid panel, where I start out with, for individuals, I do a TSH, a T4, T3, and I come down and I run the TPO antibody and the TG, which is the thyroglobulin antibody. That is my go-to. And I pick up, if you're going to have a thyroid problem, that probably covers 90% of people. So that's a pretty good, compared to running a TSH and you catch 20% of people out there that have a thyroid problem, you're catching 90%. Now, the other tests that are on here, I sometimes come in and fill in. If you come back in and you're looking at it and I'm like, okay, man, I am sure you have a thyroid problem, but all of a sudden everything's coming up in normal range and I know you have a thyroid problem, I may come back and run some other tests in here. So
I didn't catch that. We go down, skip over after T3.
Yeah, so I go T3, and then a lot of times I'll drop down to the TPO, TG antibody right here. That's usually my baseline. If I'm looking to see if you have a thyroid problem, if I'm suspecting it, that's what I'm looking at. And usually I catch about 90%. Once in a while I have to run another test, or if that comes back positive for something, if I do those tests and they come back, but I still don't know where it lines it, I may come back and order another test in here too, is what I usually do. Yes?
So if you're on medication right now,
Perfect.
how does that fit into the results you're going to get? Because you're already screwing around.
Correct. So that comes down to your clinician's skill, is what it comes down to. Being able to look at blood work for years and say, okay, you're on 100 milligrams of levothyroxine and 5 milligrams of lithothyroxine. And so now I'm saying, okay, that's going to bring us up about this much based on your weight. So I'm here. Okay, that seems normal. We're looking at a primary. But I may come back in and say, you know what? You've been on this medication for a long time. Let's go ahead and just run these antibodies. And if I run those antibodies, I may find that it's positive. Your TPO antibody, for instance. I say, hey, you have this TPO antibody. Let's do something here. Let's have you go off gluten for 2 or 3 months. You come off gluten for 6 weeks minimum, but as usually I do. You come off that TPO, you come off the gluten for 2 or 3 months. Well, then all of a sudden you happen to go to your doctor and they draw your blood work and they'll say, oh my gosh, your TSH has dropped down. You need to come off your thyroid medication. It's because we just solved the problem that was going on. So a lot of times I've actually had patients in the past where we've done that. They've come off gluten and their TSH drops down below normal. I'm like, well, you made me sicker. My TSH dropped down to nothing, you know? Like, because you're taking a medication that you don't need to be on, you know? You were taking a medication to treat the symptom. We found the problem, and you cleaned it up. So a lot of times, you'll see people have those changes where their thyroid levels go up, their TSH drops, and you're like, that's great news,
but
you know?
It would be important to have the second test done.
Yeah.
Right at the end of your projected period of.
Yeah, and it kind of depends on how much thyroid you're on. If they put you on, so a lot of times we can calculate out and know, okay, what your body weight is and what you should be on. Well, some individuals are actually quite a bit above their body weight, what they should be on. And the reason is it's getting bound up in the antibody and everything else. It's just not usable. So at that point, I would say, okay, you're going to go gluten-free. We know you have a TPO antibody. Let's test in 3 weeks. Because we're going to test in 3 weeks, because if you happen to start going high, we're going to have some other problems, and I'd like to know it. And we may test again. And that testing, I think one of the last things I put cost of the testing, so that testing would be cheap. Like, so if I was going to have you come back in 3 weeks, I'd run a TSH, T4, T3, and I think like $35. So in 3 weeks, it'd be worth the $35. We'll know more here in a second when I get that screen. But anyway, that's how you have to do it. This is when you start looking at this puzzle. Let me see if I have. Let me go on and I'll show you a better one here in a minute, because there's one that you can actually fill in your numbers and stuff in it. So food sensitivities. When we suspect a food sensitivity, the big thing, the most common are the big six: wheat, dairy, corn, soy, sugar, and peanuts. And if you came to my food class or any of my other ones, I talked about the big six. I will tell you, every one of those is inflammatory to every individual. There's a reason why they're inflammatory, and most of them are due to modification, is why they're inflammatory to everybody. So if somebody comes in and they're like, hey, I can't afford the food sensitivity, I say, very least, go do the big six. If they can afford the food sensitivity, I say, let's run the food sensitivity. There's one caveat in there. Sometimes on the food sensitivity, you will come back gluten negative. There's, I think, 17 types of gliadin. Some food sensitivities are only running it for 2 or 3 of them, and they're not running it for, like 14, 17, the big ones in there. And so sometimes if you have a TPO antibody, you have a gluten problem, because the TPO interacts with gluten. There's no doubt about it, even if it comes back negative. So a great example of this, my wife has Hashimoto's. She has a TPO antibody. It used to be way high. We take out gluten out of her diet. Things are better. We still struggle with some things in there with her thyroid. But her gluten sensitivity has always been negative. Every single time, all the way back. And I've ran multiple different ones. It's always negative. If she gets gluten, she looks like she's 9 months pregnant within a short time period. And it happens, I mean, just like that. And eating and coding and telling people your gluten sensitivity is about useless. You pretty well, it's the wild, wild west of that. So she has a different set of clothes for when she gets gluten, and it lasts for about 4 or 5 days before it goes back down. So it could be. We'll see. Mycotox, fungus. If you got little fungal infections, if you got that little place that's itches, a little dry patch, clean it up. If you got yellow nail fungus, you got big nail fungus, clean it up. Your tongue is white, clean it up. So we run some mycotox tests, but I will tell you, in Chinese medicine, you can pretty well quickly, if you have a good physician and they're looking at your tongue and they're looking at your toes, they're looking at your feet, you can tell. And I will say, a lot of times it's going to be a lifelong struggle. You get these fungus growing, and you're like, okay, I cleaned it up, I got rid of it, I did everything I did, all my tests show negative. Well, I mean, all it takes is, your test was showing blood work, that kind of stuff. All it takes is one little piece in your fingernail that touches the nail bed underneath of it, gets in your bloodstream, and so you were clean 6 months ago, now you got it back. So it's kind of a constant battle. Where you really work with mycotox and fungal infections is cutting that sugar. You got to cut the sugar. Usually sugar and dairy. That's your two, because fungus loves lactose. It loves lactose. It loves to grow on it. So, well, that's how you make cheese. I mean, literally, that's how you make cheese. So it loves it. And so if you're eating dairy, if you're a dairy holic, you will have fungal issues. You'll have mycotox issues. So diabetes, is the other big one that I mentioned in here, and it's a big deal. We run a comprehensive metabolic panel. It's cheap, and an A1C. Just see where you are. We're working on getting some continuous glucose monitors. We'll basically put it on, and it will change your world, even if you're a healthy individual. The things that spike each one of your glucose is totally different from one person to another. You may have one person that can go out and actually eat candy, and their glucose goes up and kind of just tapers down. But they go out and eat a piece of bread, and it goes wham through the roof and drops down. You can have another person that they eat fruit, causes no problem to their glucose because their liver is real slow about taking the fructose and breaking it into the 2-glucose. You have another person who's basically able to take the fructose and break it down real fast, and their blood sugar shoots through the roof. So every person is different. That's why that glucose monitor, they're kind of expensive right now. I keep thinking they're going to drop down cheaper, but it's anywhere from $100 to $200 for them. Well, the problem is they've made them prescription only, and so that's why they weren't to begin with, and so the price dropped. We can.
It's not the right ones, but I was looking at them online.
You're still getting it through a prescription online.
Oh,
yeah.
They're just giving you a prescription.
Yeah. Infections. So we run a CBC just to test your white blood cell count, red blood cell count. I will say this: most individuals can't read a CBC. It's not possible. Maybe someday I'll do one on reading your blood, reading your comprehensive metabolic panel and your CBC, and just do one on that. So a CBC tells you your white blood cell count, your red blood cell count. It tells you all your indices of your red blood cells, how big they are, how much hemoglobin they're carrying, how many new ones you have, how many old ones you have, what size they are. But it also tells you what percentage you have of each one of your white blood cells and what kind. So when you look at it, you can pretty quickly say, your white blood cell count is always low here, and it shows that your lymphocytes are low, but your neutrophils are super high. Oh, you've had a long-term bacterial infection you take care of. It's very simple to look at it if you know what you're looking at. But a lot of times I'll get people in here that I just reviewed blood work before I came in here, and they have had a problem with their white blood cell count since 2008. And the problem is, when you go back and look on their CBC, on their comprehensive metabolic panel, their globulin was low. When you look, they've always been low fat. Their cholesterol's low, everything's low, so they can't produce enough globulin to produce enough white blood cells, so they're always sick. And so that's stuff on that's important.
So when you have a new patient, you like looking at intervals?
Yeah. So everything you'll give me, I look through every bit of it. I have no problem looking through it. And so I have a lady last week brought in a copy paper box full of all of her stuff. And so I go up to the front desk and I take each page, I look at it, and I hand it to Christy, I say, okay, copy that one for me. And I sit over here, so then I wait so I can go back in the same place in the box, flip through again, get here. Or we have the hospitals. If they say, well, I've been to 4 hospitals, we say, okay, talk to Christy ahead of time. She will send in records requests, and we'll get that all in. And I'll look at it all.
And do you prefer paper or emails? If I just download them and...
If you have it downloaded, you can email it. She'll print it for me. So, yeah, bring it in, and then she prints it out. I can read about 300 to 400 pages of paper in about 3 to 5 minutes. On the machine, it takes me hours to do the same thing. So it's how my brain works. So when you look at a screen, and TVs aren't quite the same as computer screens are flashing.
Yeah.
And so when you actually go to read something on a computer screen, your brain has to re-register every half a second or every tenth of a second. Okay, where am I? Okay, what is that? When you look at it on paper, you can go right down and go, okay, I don't have to figure out where I'm at. I know where I'm at. And so paper is the better. Yeah. Paper is better if you're going to read anything, period, is on paper. So, yes, ma'am.
Going back to iron, would you say that it's because of iron that hemoglobin gets carried through the bloodstream?
So hemoglobin carries iron. So there's ferritin, which is a protein, and it kind of carries around iron, is what it does. Then on a red blood cell, you have heme. And heme uses iron to grab a hold of oxygen and carry the oxygen through your body, is what it does.
And that's oxidation?
No, because oxidation is rust. So you could call, in a chemical standpoint, you could say that's an oxidative reaction. But your body then exchanges it for carbon dioxide, which neutralizes it, and it goes on its way. So that's not oxidation. That's a little different situation. Yeah. The hemoglobin is very special in the fact that it takes the oxygen on, which makes it oxidize and it rusts. That's why it has the color. That's why blood has the red color. And that's why people are, the more hemoglobin they have, you look inside their eye, they're redder right there on the campus there. And then as soon as it gives off the oxygen, it takes on carbon dioxide. So if you actually take somebody's arm, you look at it, these veins look blue. It's because they have carbon dioxide in them because they're veins. If you can take and actually cut me open and you get down the arteries, which are farther down inside of you, they have more of a pinkish hue to them. They look a little different. So yeah, it makes a difference there from whether it's oxidized or unoxidized. Hemoglobin's special in that point. And then on infections, one thing to say is then sometimes we do some advanced testing. The lymphocytic mapping is one. It's fairly expensive. I don't want to say it's like $800 or so, but it tells you where inside your immune system things are breaking down. Maybe you don't produce enough lymphocytes that are T helper cells, and you have more T killer cells and things like that. It's a more advanced test. I've used it for people that when they can't figure out what's the matter, I've come back and used it a couple times. It makes a difference. I had a patient who thought they had Lyme's disease. We did that and found out it was a different situation. And then advanced testing like Epstein-Barr testing, different virus testing that we do there. So mitochondrial dysfunction and oxidative stress. I pretty well covered this. This is your mitochondria. I was talking about Golgi bodies. That's what this is over here. They're your packing stations that move it. And then basically that's your nucleus that replicates the cell there. But whenever you get oxidative stress, it's going to cause a problem here. When you get too much sugar, it's going to cause a problem here. Toxins tends to cause a problem cellularly, which then that cell says, okay, shut this system down. We can't handle it all. There's tests for this. Genova makes an FMV test, which goes in and tests all of your oxidative stresses. It tests all of these chemicals that are coming out here. It tests also all of your metals, heavy metals and that. And so that's the test I use for this, and it's actually very effective for that. Yes.
Is there more than one mitochondria?
Oh, yeah.
Per cell?
Yeah.
How many?
It depends on the cell. So muscles have a ton of mitochondria because they have to have a lot of energy. Fat cells may have one because they don't take much energy. So the more energy the cell has to have, the more you have in it, the more mitochondria you have in it. So it makes a difference. Yeah. Mitochondria are interesting. They have a totally different genetics than the rest of the cell. So at one time, they believed mitochondria were actually its own living organism, and basically it got pulled into a cell and became part of the cell and it's transferred. Mitochondrial DNA, by the way, only comes from the mother. So if you wanted to look and see if somebody basically, if you had twins and that kind of thing, you want to see how it played out, you can go look at mitochondria and figure out who the mother was. So if you had two identical twins and they were both perfectly identical and you had a baby and they both said, oh, it's my baby, instead of cutting the baby in half like Solomon did, you can say, let's go test the mitochondrial DNA. And you can test that out and figure out who it came from. So it's kind of interesting that way. We're getting close to the end. I want to explain to you why also in an area like Cody, people miss thyroid problems. And so whenever they test blood, they basically come in and the middle here is 92%. It's not quite equal, but 92% of all your patients that come in, they test their thyroid and they say, okay, this is our bell curve. Everybody that's in our 92% of everybody we tested is what we're going to call normal. So that's in your normal range. Well, let's say in Cody, 50% of the people that have a thyroid problem are not tested, are not treated, I should say. So they have a thyroid problem, they're not treating it, so they're sick. So you tested them, and now all your sick people, instead of being out here and out here, are now, you're starting to throw sick people in here. This gets wider in Cody than it does somewhere else. Well, the only way to get a true functional type thing, I'm going to go to the next slide. So this is the bell curve again. So this is called your pathological range. This is what you would get if you went to the hospital, they would say everything in between here is normal. Well, there's doctors out there that have said, okay, these are the healthiest people I know. Their thyroid's function good. And so they did find 1,000 of them, and they find here's the range you do on them, and this is a normal range. And that's called your functional lab range, is what it's called. So when we look at thyroid, by the way, I apologize. I didn't get these put in. These are from local, either the hospital or through Billings Clinic and stuff. So these are what they call normal. This is what the medical world in general calls normal. And this is what they would say a healthy person should be. So when you look at it, the functional range is where it should be. Now some of them are the same all the way across. But, if you, for instance, take that T3. Remember, T3 is your functioning thyroid. What makes your body work, speeds it up and everything. This is what here in Cody, the hospital, the clinics and everything, would say is normal. So that big range is normal. The pathological world, so basically if you took all the hospitals in the United States and said, what do they say is normal? This is what they would say is normal. Then, if you took a healthy range, this is what healthy range would say. Healthy people are in this range. So, a lot of people are going to come in here, and be somewhere between 60 and 100, and they're going to say, you're fine, there's no problem. And that's all they run, And again, if you look at TSH is the most ran test. This is basically what they'll say at our local hospital. This is what functional range is. And you can see there would be a lot of people out of that functional range. And they'd say, oh, you're perfectly fine. So if you come in and I'm looking at your old blood work and I say, okay, this is your TSH. And you say, yep, doctor says I'm fine. Well, the functional range, your range is not in the functional range. If you don't mind, let's run a couple more tests. We come back in and run the T4, T3 and find out, oh yeah, you have a thyroid problem and it's been missed. So that's what goes on with that.
So when you're reading tests that are older, you're also taking into account the area of the country it was done in?
Well, some extent. But if you take it all back and say, this is the healthy range, it wouldn't matter where it is in the country. You want to be healthy compared to what's normal healthy. So even whether this was ran, let's say this is the normal in the country, this is the average in the country. So it wouldn't matter whether you're in New Orleans or Cody or whatever. If you fall in here, but you're outside this range, I'm going to take a little closer look at it. I'm also going to say this, blood work is a snapshot in time. So basically one time I might catch you going, next time smiling, next time. If I see enough of it, that's why you asked me about old blood work. The more you give me, the more now it starts looking like a video. So instead of just having one or two, I can see like, yeah, she always had her tongue hanging out, and so I need to fix that. Or I can say, wow, she had her tongue hanging out here, but then over time she got to be smiling and she's doing good here. Or just the opposite. I can say, wow, look at this. Her thyroid was high and it got higher and higher and higher and higher and higher, and then all of a sudden it started dropping down. Let's go test those antibodies because you basically went into Graves and you dropped off into Hashimoto's.
So in the big world of your master number, is it just U.S. data or is it
U.S. data? Yeah. There's some. I will say for the functional range, some of the functional ranges were pulled with healthy people out of Europe and stuff too, so they pretty much matched up. Healthy people pretty much matched up all around the world in the functional range. Because you can go to, there's probably 10 different professors that have done functional ranges. They're really close. I mean, within point whatever of each other, they're pretty close. The pathological range changes from time to time, and that's just because people ebb and flow. It changed probably the most during COVID because everybody sat at home on their booty. Yes, ma'am.
It's mostly women who get tested, but would you say that it's equally prevalent in men and women?
Close. Very close. I will say this. Women tend to be more carb eaters in general. And that's changing, by the way. It's changing because it used to be up until probably 2000, somewhere in there, more obese were more women than men because a lot more women were at home, and now things have really transitioned where now actually more men are at home than more women are working in a lot of cases. And so as that sugar, when we get that oxidative stress, sugar diabetes, we've actually seen it switch from being women to men, And so I'd say now, pretty soon, you're going to see more men have thyroid conditions. The other thing that mixes in with that is pregnancy. Your immune system goes up and down, your thyroid goes up and down, so women are more prone to throwing antibodies for stuff than men. So that's why you have women have more of it than men. So it's an antibody situation. You have a baby, and your immune system automatically goes down so that you don't kill the baby. It's a foreign invader in your body, and your immune system has to drop. When it comes back up, you think it's going to come back up to level. It never comes back up to level. It drops, it comes back up, maybe it goes high, and you start throwing antibodies against yourself because it thinks you're the invader, or maybe it comes up and it comes up low, and you're sick as can be, and you're like, I was never sick before I had a baby, now I'm sick all the time because your immune system didn't come back up the same. I've had a patient a number of years ago, she had 2 babies. Second baby, she came out and she was sick for like 3 years, just sick all the time. Her immune system was just depleted, wasn't good. She got pregnant a third time, had a third baby, came back, had no more problems. So babies are rough stuff. They break your bodies and everything else, so it's rough on you. I put this slide in here so that way if you wanted to punch in your numbers, so it would put it up, you just drop your numbers in here. I will say this, make sure that you're talking apples to apples. So a lot of times you'll have a uniliter or whatever in there. You got to make sure it's the same. So you might say, hey, I have 180 and he has 1.8. It's because of this is milliliters and not deciliters. So you got to make sure that the units are the same. If you ever have a problem with that, the units are different. You put in you type in Google 180 uniliters per deciliter equals how many uniliters per milliliter, and it'll give you the answer. So you can convert it if you need to. It does it really nice. Once in a while, I have an issue. I have an issue if both of them are changed. If they change uniliters and milliliters both on the thing, it's a lot of calculations, so I use Google to do it. Most of the time, if it's just milliliters changed to deciliters, I know I got to change 1 decimal point and I can fix it. Not a problem. But anyway, this is a master chart that you plug in your numbers, and you can go across and kind of figure out where you're at. It's not foolproof, and there's a lot of things, like if you're on a medication, it can skew some things, but it's a pretty good telltale in there. We were talking about price a while ago, so I was off a little bit. Things are higher out here than they are in Missouri. So it'd be $54 to do the TSH, T3, T4 in there. But I think to do TSH, T3, T4 and the antibodies, it's like $139, which is cheap. Because we have to charge a $10 lab fee. That's what's not on there, is a $10 lab fee. That in most places is like $540, something like that. If you go and get it, especially if they run it through insurance, it's going to be somewhere between $540 and $1,500 is what it'll be.
Is the 240 food sensitivity quite a bit more expensive than that?
It's on there. $499. By the way, I didn't put this in the book. She has this list up at the counter. So if you're interested in grabbing that, she can give you the price. I put a little on the other thing. I put this in right before I walked in the room in here. Because I thought people are going to ask me how much it is and I don't know the answers. So she printed it out. I put at the bottom a disclaimer. That price is for a day. I don't know what it's going to be next month or whatever. But so, because inevitably you'll have somebody come in and say, well, you told me. So, but these are good prices. I go to every company and I negotiate the price. And I did that here in Cody too, and it was a battle. It took me like 6 or 9 months to get good prices here. And I still say they're not as good as I had in the past. And I'm actually working with something else to get these even lower, because I don't want that to be the reason we don't find something for somebody, is not to get the testing. So it's a big deal. So yeah, and it's a big deal if you can come in and get a full thyroid panel for $139 compared to $500 or $1,000. And this is a true story about myself. 3 years ago, I was having some digestive issues. I was having some other problems, just fatigue. I wasn't feeling good. I was having all kinds of problems. And I knew I was having problems. And I ran a bunch of different little blood work. And I went to my wife and said, I'm going to quit working. I'm just exhausted. I can't keep going or anything. She goes, what would you tell a patient? That's her go-to. Anytime I complain about it, what would you tell a patient? I tell them they have food sensitivity. She goes, why haven't you ordered yet? This is $500. And she's like, so why haven't you ordered it? I come in the next day and the kit's on my desk and it's already been paid for. And anyway, I did the food. Anyway, it came back to be tomatoes were off the chart for me. Tomatoes are like poison, and they still are today. I got a little bit at a restaurant the other day. I thought, oh, it looks good. I'll try it. I was sick for a week. So anyway, it changed my life by doing that food sensitivity. It was well worth the $500 in the end. I still like tomatoes, but.
So even old food sensitivity tests from other companies, like I have a couple old ones they only tested about 120.
Yeah. So it depends on the food sensitivity. Some food sensitivities come and go based on cross-reactivity and stuff like that. The ones that don't tend to come and go very good are gluten and dairy. They tend to stay with you pretty hard. And the reason is they cross-react with other things in your body. And so once you have it, your thyroid keeps telling you you're seeing gluten, so you keep it up. But
I'll just throw them in there. But
yeah, without a doubt. I will say I've learned to experience. There's a couple companies out there that are trash. And the way it worked out, Vibrant America is one. They make a really pretty printout. It's really great. It shows you all these great food sensitivities and everything. But I had a lady that lived outside the town that I grew up in. She came to me and asked me if I would do Vibrant America, and I did it. But one day they ran the same patient twice. So one day I get the results in on a patient. Next day I get the results in on a patient. And I called her and I said, I got 2 separate results on the patient. And I said, are you sure you ran them on the same patient? So she calls down and goes, yeah, they actually ran several batches through the second time, so it's the same patient. I said, okay, these results are totally different, like way substantially different, like not even the same. So I said, are you sure the same patient? She goes, yeah, the same patient. I said, okay, what should I do with these? You know, I said, they're different. She goes, oh, just choose which one you want. It doesn't really matter. I was like, we're paying for this test. And so anyway, I talked to the doctors and there's a lot of doctors that stopped using them. I still see their tests coming through all the time. And so I stopped using because as soon as I was told, oh, just pick whichever one you want, why are we spending money and why are we running it, you know? And then, there's a Dr. Manny out there who sells to people who do functional health. He kind of sells them a course on how to do stuff. And in his course, he sets you up to run these testing. And 2 of the tests that he has you run have food sensitivity panels tied to it. And he was basically like, okay, whichever one you like the best, take it, if they come in different, you know. And so that became a problem again. So then I started looking and trying to find companies that tested for known antibodies. So they had controls where they could say, we know this person, not just testing the element, but testing the person. And so there's 2 or 3 out there that are testing to make sure that so you can test for sensitivity, you can test for specificity, but then you still, if you test with a control, then you know. And so there's a couple companies out there that test with controls, so you know. So the answer is yes, I look at it, but I consider the source of it too. It's a big deal, and there's several tests that are that way. There's some of your gut biome tests are that way too. People will have some of your hormone tests, depending on how they're taken, how they're done. I'm leery about them. So my first career was working in a lab, and so knowing how quality control works, knowing how the lab tests work, and all that, you real quickly figure out what's going on with them.
Right.
Yeah, you can. If people are running a food sensitivity test, for instance, on Facebook and that kind of stuff, and it's going to be less than $200 at least, you might as well not even do it. If they're going to pull a hair follicle out of your head and measure your food sensitivity, you're joking, you're kidding yourself. So there's things like that don't matter. Now I will say I had a problem with ones that were a finger prick, and because when I first started out, you had to have so much serum to make it work out. Well, now the tests are so sensitive that they can do it really well from a finger prick test. It didn't used to be that way. A saliva test is not going to get, it's going to get IgA, it's going to get IgE. So a food allergy or a super mild sensitivity, it's not going to get an IgG, which is the ones that you have a lot of your reactions to. So yeah.
Which type of test are you using? to invest for food sensitivity?
Yeah, so we're using a finger prick now, so we can do a finger prick or a serum blood test in there, and it's through US Biotech is what it is, and it's a good test.
Finger prick?
It's a finger prick is what we're using with them. Yeah, and I had a problem with them. We were doing the serum test, and then we came back and found out, okay, it's testing the same because they have new micro testing, and so that blood spot test and that are coming back with the same results. So we were happy. They did a good job convincing me, and because at first I was like, no, you got to have more serum than that. But we were doing electrophoresis, so you had to take a pipette, put a little drop in each one, and then run it across the page. They can now come in and micro test it with a microscope so easy that they're doing it good. So I think that's it.